Genji.
Fine.
No video?
Currently used off-label in dental and now medical settings. Dr. Fontana, please take it away.
Also, I'm not sure if this is something, but she also sits on our executive rep board for CHEAR, so thank you.
And that way I can see everyone, and it's so nice to be here in person. I think the last time I was in person at your CHEAR building was when you were back on campus, and then when you moved, it was just so much easier to do it via Zoom. But there's nothing like being in person, right, for some of this collaboration and discussion. So I love your facilities here. So thank you for having it, and thank you for the invitation. I know this, I look at, follow closely your CHEAR seminars, and so this is perhaps a little bit of an unusual topic, talking a little bit about oral health. But given everything that is happening right now in the news, et cetera, and certainly oral health with fluoride has been in the news, as well as vaccines and other things, right? And I can tell you from working with NIH and CDC and FDA that there's very interesting pauses or not pauses. Sometimes you can engage with some of these agencies, sometimes things have been frozen, as you know, in the conversation. So I thought this would be, thank you for inviting me last semester to do this. But it would be a nice conversation today about how this plays. And I chose two projects. The second one, just because medical providers, as you know, last year had a code that you can use now to use SDF in medical settings, as you do with fluoride varnishes. So I thought it would be interesting to tell you, because it ties into a strategy that is used in dental and now medical settings. There's a nice module on Smiles for Life that has been put up on SDF, et cetera. So tell you a little bit about the work that we're doing in trying to get a drug application for this. This is approved as a medical device right now. And then the first part, because this is a project that has been going on in its 13th year, and a lot of the renewal has been with folks from CHEAR. By being in this executive committee and learning a lot of the work that different people in your unit or associated with your unit do, we have collaborated, and many of these folks are now co-investigators in the third phase of this grant, where these kids are becoming pre-adolescents, right? Or we have had the wonderful opportunity to work with Lisa and her group in doing some cost effectiveness analysis on some of the risk tools that we have developed. So it just seemed like the conversation would be natural by focusing on this. I'm going to be giving you a very high view of the two projects. I'm not going to enter too much into all the dental details. It would probably be a little bit boring. But I want to explain where the synergies are and where the possibilities for future work, and also letting you know some of the data that we have, because we have a lot of data that we're sitting on that could lend itself to a lot of other projects if interested, either by your students, yourselves, et cetera. So, and this is meant to be a conversation. I don't have many slides. I think I have like 30 slides. So we should have plenty of time to have conversations. And like I said, I didn't go into the nitty-gritty details of a lot of the data, but just giving you a little bit of a broader picture. Okay. And disclosure, I don't have any financial interest with anything, but we're funded currently for these two projects. These are two ongoing UO1 and UH3 grants from NIDCR. So obviously, I have to tell you that. So when you look at the global burden of oral diseases, so in blue is caries and primary dentition, the orange curve is in permanent teeth. Then you start to see teeth falling off, which is that green curve, which actually we have reduced tremendously in the US throughout the last decades because of fluoride. So getting our students trained to put dentures is very difficult nowadays because the rate of edentulism in the US has dropped dramatically, which is absolutely fantastic. But dental caries remains a problem. And I'm going to focus the discussions here on children because obviously this group is very interested in children. But I can tell you the situation for adults is not necessarily much better. But this is one of the most common chronic diseases. This is a non-communicable disease. It's extremely common worldwide. The disease in children is called early childhood caries, but it's the same disease as in adults. This is the microbial dietary promoted disease where pathogens are part of your normal flora. Untreated cavities is one of the most a single condition globally prevalent. Billions of people and billions of children around the world suffer of dental caries. In 2024, the global economic burden was estimated to be around higher than $700 billion. So this is a very, very costly, not only for treatment, but then the impact on quality of life, loss of work or loss of school days, et cetera, and everything else that goes tied with that. And there are larger inequities and disparities that have persisted. And even though we have done really well with some parts of the population, some really do not have access. And the differences, the magnitude in differences has expanded rather than closing. And this is tragic because we have strategies. We, in general, know how to control it, but some of these things just highlight how important social determinants of health and everything else, the environments that our kids grow in, are influential in disease. And, unless you cure poverty, a lot of these things are very difficult to address, right? And even when you have access to care, you still see some of these disparities and inequities, which Gary and I have been talking a lot about because that should not happen. At least once they have access, right? So we do know in dentistry that obviously, I will tell you, getting money for dental health, the NIDCR, fortunately, we still have that institute. I don't know when it gets collapsed into something else, if it does, what the level of funding might be. But of course, you heard discussions about condensing all of NIH's institutes, et cetera. But they're the primary funders of randomized clinical trials for evidence-based guidelines in dentistry. Industry will run some, but other than the big push towards when fluoride toothpaste were developed more than 50 years ago now, most of the trials have been funded by federal agencies, and there's not a lot of trials, which is part of the problem with a lot of things in dentistry, that the level of evidence is lower. It's very small trials in many cases, except for a few things that we know really, really well. And fluoride is one of those things that we know really, really well, that it works. And if used correctly, is very safe.
Could I ask?
Yes.
Why is it different for oral health that the clinical trials are run within the NIH rather than industry?
Because industry has found a way, except for toothpaste, there's very few products that are approved as drugs for oral diseases in the United States. Dental companies are much smaller compared to the big pharmaceutical companies. And so they have found that they can get products into the market through the back door as medical devices. And so, for example, floor varnishes, which you are very familiar because, of course, you hopefully use them as part of well child visits, et cetera, are approved in the United States as a medical device, just to plug areas of the tooth that would be related to sensitivity. That's much cheaper for the manufacturer to apply to the FDA for that. The level of what they have, the data that they have to show is very, very limited. And by the way, they just showed a little bit of data in adults a long time ago. And everything else that comes into the market is based on that old predicate device, where the mechanisms of action are so different. I mean, this is a whole argument, which is why I'll explain why we went the SDF pathway. But that's part of the problem. They can come into the market through that back door. They don't need randomized clinical trials to get that approval from the FDA. And they can sell it, and they're doing very well. I mean, that is a very large market. And there's large concerns by many of us that obviously we assume all these products are the same. And clinicians tend to buy the cheaper one, perhaps the only one that they know. But there's laboratory data to suggest that they're not all the same. And there's concerns that we're using a wonderful public health measure without good data on efficacy clinically. And a lot of the old products that we have trials from in other countries they don't exist anymore. Manufacturers have moved away from those components, et cetera. So the current products are very different than the original ones. So that's the situation in dentistry. So other than your fluoride toothpaste that we know work very well, everything else is kind of regulated through this back door as medical devices.
Okay. Quick question,
Yes.
is that different in other countries? Like, are we unique in some way?
We are unique. I mean, I think, yes, some of the products that exist in the US that are not approved for caries as a drug, as a drug for caries are approved in other countries. The regulatory burden is different. There are trials in other countries that have been done. In the United States, just this SDF trial that we had to do to try to provide data for the FDA, talking about over $10 million for a trial. So, and these companies are very, very small. They have one or two products that they sell very, very cheap. So to recuperate that cost is very, very difficult. So that's part of the challenge. And the FDA, as you know, will not accept trials done in other countries, at least for oral diseases. They require trials done in US populations. So the trials have to be done here, even though we might have good data from other countries. So that's the situation where we are right now. So you all know, I hope I don't have to convince this group about the importance of this interprofessional care, particularly for oral diseases. Like I told you, many of these young kids, particularly those from groups of the population that have difficulties accessing dental care, which are many, unfortunately, in this country, either because they can't access care or because, quite honestly, the dental workforce has been trained to not want to see those kids because of the way the specialties took over. They said, this is our domain, so don't train dentists, general dentists to see kids. We are gonna see them as pediatric dentists, but we don't have enough pediatric dentists, right? So who's gonna see this kid? So I feel your pain when you say, I want to refer this child, I just don't have anyone to refer it to, or I don't have the dental workforce that will accept Medicaid or something else, which is the other barrier. So there's many barriers here. The solution is not complicated, but that's why the big push to get medical providers early in childhood to be involved in recognizing dental diseases and just starting basic prevention, knowing that would be the biggest issue that we have difficulty getting this young children to. So anything that you do regarding getting kids used to using a fluoride toothpaste as soon as teeth are rubbed, and then providing fluoride varnishes, is a huge advantage, and then putting them in contact with a dental home, hopefully, to do that as well. Two pieces of this risk stratified care are the need for accurate risk screenings, right? Particularly, and I'll tell you how I got involved into this. I was working at Indiana University at the time, and Indiana was one of the last states to come on board to say that they would pay for fluoride varnish to be done in medical settings. The reason why they were so hesitant is that they didn't have enough money. So they said, if all of a sudden every child and every pediatrician decides to start applying fluoride varnishes tomorrow to every Medicaid child, we just don't have enough money. So we were doing other collaborations, and they came to us and said, we need you to help us stratify based on evidence. Tell us, if we had to choose, who would we apply it to that would benefit the most? And we said, well, we can't really tell you that until they have the disease. Once they have the disease and you see signs and symptoms in the mouth, then the prediction becomes much easier. But we really don't have good ways of telling you ahead of time. And so this basically delayed. Indiana was the last state of all the states in the United States to start paying for this because they just couldn't get around the fact that they didn't know how to pay for this if it was going to be very successful. And that's how this grant started. This grant started by saying, okay, we need to fix this. We need to be able to provide a way to screen these kids early on before they have teeth or when teeth are erupting. We don't have a lot of history to look at, to be able to guide medical and non-medical providers, to be able to provide and stratify, refer more effectively those at higher risk, and determine who might benefit the most from some of these strategies. Beyond the preventive for all approach, which is very important as well, right? Okay, in dentistry, if you look at the majority of studies regarding where we are with development of prediction tools for decision making, most of the studies in dentistry are in this initial steps, and none of them are really interprofessional. There have been studies where you look at microorganisms, habits, diet, sugars, etc., health of the parents, and the environment in which the child is growing into, and how those individually or combined can help determine what the child might look like a few years after that. Those tend to be in very small populations. If they find something, it is rarely repeated and cross-validated to see if those same findings stand in different population groups. We have very few of these impact studies that say, okay, well, if you're going to stratify kids on risk and you're going to apply different protocols, what does it look like at the end? Are you improving health? Are your outcomes better? Are the costs reduced, et cetera, et cetera? Of course, you can't get there if you don't have good prediction or stratification tools that are based on evidence. So we're kind of stuck in this middle ground. You know this very well as well, that the current policy and the decision at the time by the AAP was to not do a risk stratified, but that every kid, right, that comes into your well child visits will get a fluoride varnish, and the rate of reimbursement or who is being reimbursed varies a little bit by state, but it's generally right now limited to young kids. Okay, the decision to not do it stratified, even though if you refer that same child to us in the dental setting, we won't apply fluoride varnish to everyone. We will apply fluoride varnish based on risk.
Really?
Yes. So the policies do not match. But the reason why the decision was made at the medical setting, because I remember we had those discussions for a very long time, is there was no good way to train or provide evidence on how you would stratify. In a dental setting, we have much more time to get into detailed, very long, detailed conversations with parents, et cetera, to try to predict the risk of that child. And then the guidelines from the American Dental Association, American Academy of Pediatric Dentistry is that you apply this extra products to those that are at increased risk. Yes.
Don't you get more? When you go to the specialist, isn't the notion that you probably get stuff more than less often than at the primary care arena? You know what I mean?
Depends what it is. If it's a population-based intervention, I would say for diseases, yeah. For prevention, probably not.
Oh, yeah. Yeah. Now, these products work both for primary prevention as well as to manage the initial stages of the disease. So if you have Caries solution developing on the tooth, and initially you will see it as a spot, the minerals on the tooth will look like a spot on the tooth. Eventually you'll have a hole, right? But once you start to see those initial stages, these products can help treat that as well. So they can function in multiple roles. Yes.
And there's no downside to fluoride varnish.
No.
That would
So
really
that-
be push of the
Yeah, but why wouldn't
AAP.
you guys do it for everyone? Like, do you have cost constraints?
Because of cost. I mean, there's no reason to do it to everyone. There's data, there's clear data from the dental side that shows that kids that are low risk do not benefit from these additional strategies if they're using fluoride toothpaste.
How much
Right.
is it?
It's not very expensive, but there's an expense which is an access to care issue, right?
See, we
So-
would say that it costs more to screen, to take the time to screen than it does to just do it.
Huh.
Yeah.
Interesting.
But you have to do it well. That's the other thing with the fluoride varnish. The fluoride varnishes work by staying stuck to the tooth, so the surface has to be really dry. If that varnish is peeling off right away, it's really not doing anything. You're not getting any of the benefit. So this strategy, and that's part of the problem with coming through the back door that no one regulates how this varnishes. So companies are like, you don't like it sticky? Sure, I'm not gonna make it sticky. Oh, you don't like it yellow? I'm gonna make it white. Oh, you don't like the taste? I'm gonna change the taste. And as you're changing all of these things stay less stuck to your teeth. And they don't work the same. It's very likely that some of the products we have on the market nowadays, they might contain the fluoride, but they're not releasing the fluoride. So no one is getting a benefit. Regarding safety, because right now everyone is talking about IQ and fluoride and et cetera, these topical products have no chronic effect at all because the exposures are so sporadic that fluorosis is the best known chronic consequence of fluoride ingestion. And you have absolutely no fluorosis associated with this. So this very sporadic applications done well are not going to have any chronic. Acutely, yes, you very young kid might give them a stomach ache if you are not careful, but not chronic issues. Yeah. So from our own data, you know this nationally as well, even though this policy exists and there's reimbursement, you know, all the nice things into place, you know that nationwide, the application of fluoride varnish in children is less than desired. Within our study, and this study is running in North Carolina, Iowa, and Indiana, Michigan. When I moved here, we became the data coordinating center and managing center for the grant, but the patients are in all of those other states. Like I said, the kids are now 12, so we've been following those kids now for a long time. Between 12 and 30 months, only about 20% of the kids in the states on average are getting fluoride varnish applications. Of course, it drops with age and that's tied to reimbursement probably, but it's not equal in every state. North Carolina is doing really good, but they were one of the first ones to start. The other states are not doing as well in comparison. And there's data nationally that shows that, you know, this has been a very hard thing to get really used in practice commonly. So this is not new. And we also know, at least from the behavior of pediatricians associated with the kids in our grant, that a lot of that behavior seems to be not even driven by whether the child has the reimbursement or not, but by the pediatrician's thought of this child needs it or not. So they're already behaving kind of in a stratification approach, saying, I'm gonna give it to this child. In many cases, it's because this child has perhaps a more sugary diet or less ideal diet than this other child, even though the policy and the recommendation and the reimbursement is that every child in a medical setting could get it. So the behaviors are already mimicking some of this stratification approach. So the thought was, well, this would be an easy thing to implement because clinicians are already kind of behaving in that way. If we could give them a tool that is risk-based and actually evidence-based, perhaps they would incorporate it a little bit easier in practice.
That's your question. So those rates, I want to make sure that I understand. That's 20% of 12 to 36-year-olds getting it either in the dental or the medical setting or only in the medical setting? Because if you have a kid and they're seeing a dentist every 6 months and the dentist is providing that
Yes.
fluoride varnish, right?
Yeah.
It doesn't matter if I give it, right? I
Yeah,
shouldn't
but
give
that
it.
dentist is not providing it every 6 months because if they view the risk of the child low, they're not providing it. That's what I'm trying to tell you. In the dental setting, for the child to get fluoride varnish, most likely that child would have to have already indications of disease where you're seeing disease. Most commonly, they're not going to get a fluoride varnish unless there's some evidence of risk.
What's weird about that though then is, well, so the rate of 20.3%, I mean, we don't know that that's actually too low, right? Because we don't actually, so if we
You're right.
shouldn't hold dentists to a different standard than clinicians, right? So like, in other words,
Right.
you can't tell a clinician it should be 100% in your practice, and dentists, oh, it's actually appropriate for it to be 10% because only 10% of people are high risk, right?
Agree that the difference in the rationale and who gets it and not gets it has never made sense. But we all, I think, we understand where it came from, the history of where it came from regarding that. But you're completely right. I can tell you from this data, at least, and this is from our cohort of 1,000 kids that are part of this grant. So it certainly doesn't represent everyone. Even though we made every possible, these kids were recruited from medical homes, so they were not recruited from dental homes. And we made every everything that we could to connect them to a dental home and get them there, but this is an observational study. I can tell you many did not go for a variety of reasons. So the floor varnishes that they were getting at that age was primarily from the medical home side, not from the dental home side.
No, that's fair. I think my larger point is like, to me, the most important metric is among the subset of children who are actually at risk and 100% of them should be getting it,
Right.
what percentage of them get it from either the medical or the dental setting?
Yeah, that is a
Because-
super interesting question, but until recently it was difficult to answer that question because we didn't know about who was at risk. We could identify who had disease, right? But to say who was at risk, well,
Yeah.
we didn't have the risk study. So years before, how could I tell you, yes, you're gonna have a lot of cavities 3 years from now, and you should be getting it right now, for sure, versus not. And that's why we engage in this process, because now we could go back and say, well, who got it and who didn't get it based on how we knew our prediction tool is behaving, right? But looking backwards is not gonna help us because the policies in place and the behavior of clinicians at the time, pediatricians were behaving under the premise that you should be using it on everyone, right? And there's reimbursement. In all of the states, there was reimbursement, except for Indiana for a while, to apply the fluoride varnish. The Indiana data is not included there because obviously for a while they did not have reimbursement to apply it.
So is there like a questionnaire screener?
Yes,
Okay.
yeah. So, so again, we're here, kids are 12 and a half now. We're getting ready to begin the age 13 and a half exams. We brought a large number of people from CHEAR when they became adolescents for this next stage, because we're measuring a lot of other things that are, a lot of other behaviors that are beginning in adolescence that we believe are tied to behaviors that are happening that influence oral health as well. Trying to figure out how we can connect some of these things and find commonalities that would guide, hopefully, interventions in both medical and dental settings on these children. So this is just some of the folks in red that are connected and are co-investigators at this part of the grant that I became acquainted by being involved with CHEAR. So thank you. Thank you, Gary. And everyone else, of course, from this group. And we also got associated projects and money from NIH, and we work with Lisa and all the group, and thank you to all of you that were part of that group, to look then, once we developed our initial screener for young kids, to see whether if we then applied fluoride varnish only on those kids, whether it would be cost effective. So I think really a true team size approach. So I'm going to show you a couple of slides very quickly. If you look at the top here, this is just between, I focus 1 to 8 initially. This is a prevalence of kids that had decay. And this is decay either clinically or radiographically. And this matches what you see with enhanced data. We started with a cohort that we purposely, that this were not the highest of the high kids. You see some kids that are age 1, their teeth are just erupting and they're already destroyed, right, by dental disease. These are not those kids. These are kids that at age 1 either don't have teeth or the teeth that they have seem to be okay. Okay, and then this is a progression of disease as they age. A lot of disease eventually over time. A lot of this disease, this is dental data, but once you start with those little white spots and eventually they become holes and the holes become bigger. The progression rate, once you see that little spot is going to progress faster. And the location of where that spot is in the mouth is going to also progress at different rates. So now we have a lot of the lesion specific and tooth specific behavior of what things are really moving faster now. Before we only had enhanced data for sectional data. We didn't have longitudinal data to really be able to look at trajectories and patterns over time. We have now very good trajectories and heat maps data on what things are changing and how, and I'm going to show you a couple of those things. The other thing that I want to show you, so these are kids 1 to 4, and this is the second stage of funding when the kids were 6.5 to 8. And I think you can see the rate of disease increasing rapidly. This is traditionally, so we made an argument that this is all called early childhood caries. But I think you would understand that perhaps what's happening here is a little bit different perhaps than what is happening here. And we tried to make an argument and are trying to fight that this should be early and late disease. This early disease is associated a lot with this behaviors of going to bed with something in the mouth other than water. Whether it's a baby bottle, sugar, etc. So very diet driven. This is also diet driven, but it's happening a lot in between the teeth. You can't see it clinically. We need a dental radiograph to see it. And then we see that there's a lot of disease happening in those areas. And that is because those teeth erupt, contacts close. It's much more difficult to clean. And if you don't have a parent going in the mouth and helping that child clean the teeth, you have no hope. The child doesn't have the dexterity, right, to get in there and really be very precise on the areas that it's cleaning. So a lot of disease happening in the back of the teeth. And I won't bore you with this. The other thing is that we've been looking at trajectories because this is a chronic disease. And so rather than trying to focus on your high risk today, your low risk tomorrow, et cetera, and just looking at those screeners, trying to see, can we identify what trajectory perhaps your child is in? Can we predict those trajectories? Because if we could do this, we could think more of a life course approach to prevention that might look different for kids in one trajectory versus another trajectory. Rather than individual standpoints. I will tell you, by the way, that there is some data that this trajectories exist from, there's not a lot of birth cohort studies in dentistry, but there's a few that have been attached to medical ones. This is a very well-known one from New Zealand. These people are now in their 40s, so they have data from when they were born. And this is caries in their permanent teeth. So you have clearly three groups. What we call the low risk group, these people are not getting much. They've never gotten much. They're just kind of almost flat down there. They don't have a lot of disease. Then you have your high risk people, they're getting a lot. And every time they're getting more and more and more, that curve just keeps going up. And then you have kind of this group in the middle. And those trajectories are pretty linear, as you can see. At least this study was when they were up to 32 years of age. So if you look at that, right, of course, this was a very wide cohort of people in New Zealand. It's hard to make generalizations across the United States, but I'll show you some of our trajectory data so far. So our analysis can break the kids basically in four groups. You have the group of kids that are getting disease from 1 to 4. So these are the kids that are getting disease early on. These are perhaps the ones that we are taking to the operating room under general anesthesia because they have so much disease that it's very difficult to control. They tend to be not a large proportion in the United States, thankfully. They're highly Medicaid enrolled, and they represent a lot of our minority population groups, unfortunately. Then you have a group that remains almost flat. The different colors are different surfaces of teeth, so don't get bothered with that. Then I will call this again our low risk group. They're just not getting a lot of disease, and that curve stays pretty flat at the bottom. And then you have the two groups of kids that are starting to get disease around age 4 to 6. And that's when the primary teeth have all erupted. Those contacts are closing in the posterior teeth. So you're starting to get a lot of disease in between the teeth. Eventually, clinically, you will see a hole in the mouth, right? But that started in between the teeth. And it's very difficult for a clinician without a radiograph to be able to see that is happening. And as you can see, there's two very distinct risk groups. One where there's a lot of stuff happening very quickly, and the other one, things are happening, but perhaps at a different stage. So we can break the kids, the trajectories into kind of these four latent groups. And we've looked at the analysis as the kids age, and those groups kind of remain pretty stable. Yes.
So the kids who become severe early on, they're, like all of these groups are mutually exclusive? The trajectories?
Yes, they are. Yeah.
So if you're like an early, disease, like then like those kids in the last are just completely different because they're a little bit.
Yeah, so we purposely looked at this analysis, just trying to see if we could we place you in one of these categories? Yes, there's some of these kids that are obviously, so some of these kids will be in here, but the majority of these kids are breaking into this class where if they have disease, they have it early on, and it's fairly clearly associated with this night habits or this going to bed habits as teeth are erupting, et cetera. Yes.
What proportion of non-Medicaid enrolled children have dental insurance?
In Michigan, is much
Where-
higher than other states because our coverage of dental kits is much better than other states.
So what does that mean? Like, what is that? I mean, I have no idea, because a lot of adults don't have dental, right? Like, it's an option, you don't get it. So when it says much better, is that like, any idea?
So eligible children, most children, for example, in Michigan, are eligible to some form of insurance.
Not eligible, not
Having it.
Medicaid?
Yeah, I'm not sure. It's high. It's probably in the high 60%. So the kids have insurance. It's just not having the insurance, the barrier here.
I just wanted to know,
Yeah.
I'm just curious.
But in this states, it's different. I mean, remember, this data is from children in North Carolina, Iowa, and Indiana. So it's a little bit different, the behavior that you're seeing. But it's, those curves had remained. The other thing is the models. So when we initially did this group, we had some people from AAP that were pediatricians that were part of the panel trying to figure out what would a screener look like. And they were like, one question. We're like, yeah, that's not gonna happen. So, okay, 3 questions. And we really tried modeling with 3 questions. There was no way. So we agreed on 10 questions. We said, okay, 10 questions is easy. The parent can do it in the waiting room, or you could send that. I mean, it's not too complicated. Some of these questions are from the caregiver. Most of the questions are on the kid. And interesting, some of the questions, many are diet related questions, but there's some questions about birth, mode of birth and timing of birth, et cetera. I'm not going to spend too much time on this. We published this in medical journals. I wanted to show you the work that Lisa did in her group, and she can speak more of this. But then we said, well, let's assume based on that screener. So the screener had, based on how the items performed in the model, certain weights, so you could grade it, right? And so you could get a score, and based on the score, you could decide who's going to be high risk or who's not going to be high risk. So we used that screener to say, well, if you took H1 data and said, okay, only the kids that are going to be at risk would get these benefits, and the benefits would be very easy. Things that are not controversial, right? Having oral exams starting at H1 every 6 months, whether they are done in whichever setting they're done. Getting fluoride varnish applied to all teeth starting at H1 every 6 months. And this was a hypothetical cohort throughout childhood, so up to age 18. Right? And then once the permanent teeth erupt, getting dental sealants applied, both at age 7 and 13, because that would be your first permanent molars and your second permanent molars, right? So fairly easy, fairly basic. I would say this is a very simple preventive plan, not controversial, strong evidence, et cetera. And what they found was that versus prevention for all, this risk-based approach with this screener early on would be more cost-effective than routine practice. And that was very difficult because they found out that routine practice meant many different things nationwide. And I'm looking at Lisa because that was a difficult part of this project, right? Trying to figure out some of the transitions for the model came from our grant, if they didn't have them, some of course, a lot from the literature and what was known about those behaviors. But, and this is just, like I said, the very basic preventive plan. You could imagine how we might change some of these variables and perhaps they could look very different. And the results were sensitive to looking at a lot of variables and it still remained the same. Suggesting that this risk-based approach would be more cost-effective than doing what we're doing, which it's not happening in any case overall. I will also tell you that some of the things that we've learned from our grant compared to colleagues that are working with other populations. So this is a group that is working with some native populations in the US is that perhaps part of the risk that we do see different eruption patterns on different groups of the population. So if you have a tooth in the mouth longer than someone else who has a tooth in the mouth a shorter amount of time, that perhaps might influence that when you see 2 kids at the same age, one has more disease than the other, they just had the tooth longer in the mouth. So greater chance of perhaps having the disease or not, everything else given equal, right? So we didn't have good eruption data from some of of these population groups, but because we've been following these kids very closely, we know when the teeth are coming in the mouth and what form they're coming in the mouth. We have a genetic and
Can you go back
microbiome
one
data.
slide? I've never heard of this in my life. I think this is fascinating, that American Indian kids have more teeth earlier than.
Well, I'm not gonna say every American Indian
But
kid.
on average.
The group, the groups that were sampled here, there was a difference on the teeth that were erupting and when
That's
they were.
really interesting, right? Because like, if you think about like diabetes risk in Pima Indians, right? And sort of, I mean, granted, that's like a very extreme group, but you know, sort of like, I'm curious about the obesity outcomes, or maybe like that's the third phase of the grant, so you don't have
Right,
those
we
yet.
don't
But you
have
would-
that data
but
yet.
You would even have it for the second phase, right?
No, we don't have because the weight and all of this other variables,
Yeah.
we started to add them in adolescent in the third
Got
phase
it.
of the grant.
All right. I don't know, just, there's a whole sort of like literature around type 2 diabetes risk and oral caries, right?
Yes.
So
Correct.
it's kind of interesting to sort of see.
Yeah. So we have microbiome data on these kids and microbiome data, but both bacterial and fungal. We've been collecting plaque and saliva samples throughout time. We also got a CHEAR grant, so Johns Hopkins analyzed all the genetic data, and we're working with a group in Pittsburgh because we have that dental diseases. There's not a lot of genetic of dental diseases. Our cohort studies are super small. So we gather data from different studies and then try to do meta-analyses because we don't have the thousands and thousands and thousands that medical studies have. But something that we know, and for healthy kids, the diversity of adult saliva plaque is higher than kids. And over time, the kids' composition it starts to mimic that of their caregiver, but increases in diversity. Initially, it's less diverse. And the similarity between the pairs increase. So the kids are obviously seeded from whoever's closer to them early in life in the mouth. And that tends to be mom, but it could be dad, it could be whoever's closer, grandma, et cetera. And that similarity increases over age and they become more similar to their parent, which is why the parents' oral health was very predictive of what was happening in kids' oral health in the first few years of life. So just look at the parent's mouth. And that will tell you a lot of what is going to happen in the kid's mouth. We've also looked at transitions and whether we could predict, and we can see changes in the microbiome and plaque years before, and a lot of that is affected by diet. So when you have a lot of sugars in the environment, not surprisingly, those changes are starting to happen in the microbiome. You start to select microorganisms that are very happy living in acidic conditions in your mouth, and they are going to be producing more acids. So the disease just starts to occur faster and faster.
Fascinating.
Normal changes in the microbiome. Now, we just finishing collecting data from our previous stage 2 grant. This is just initial data from some of the behaviors at age 12. So we have some differences in how groups are responding to the pediatric symptom checklist, beverages and snacks. Nothing surprising here. Groups that are perhaps more underserved are performing a little bit worse on some of the scales. Certainly much more sugar in the diet and in the drinks and everything else. And that is not unexpected, and more caries as well, as probably as a consequence of it. Caries is tied to diet very strongly. So I'm going to skip this and bring you back here. So that is where we are with this large project. We have a lot of data from multiple sources. We have human genetic data, microbiome data, behavioral data, dental caries, very detailed data. We have radiographic data beginning at age 6. We didn't take radiographs before that because you don't need them. You can see clinically, but we started taking radiograph later on. And so we have very, very detailed data on what is happening in these children. And again, we have data, medical dental data, right? So there's a lot of very interesting things that can be done that we haven't even tapped into. So let me talk about in the last few minutes about this. So SDF, hopefully have you heard about silver diamine fluoride? So there is now a code that you can use to charge in the medical setting for SDF. There is a whole module on Smiles for Life for this. Once you have a cavity in the tooth, really nothing works other than either filling it up so that you can control the infection inside of there, or pulling that tooth. Now, the only thing that has shown that works in the literature to treat those holes, if you don't want to do either one of those things, is actually this drug. Well, this device right now in the US that has silver and it has fluoride. Basically, it's very simple in a solution with ammonia. It keeps it stable. It reacts right away. It's very, very high concentration, as I will show you. So this is fluoride varnish in parts per million, and water is 0.7, as you know, in the US. Your normal toothpaste in the US are about 1,000 parts per million. There's a prescription one that is 5,000. These are all the things that if you go to a dental or medical home, most of you will use a fluoride varnish that is this concentration in the medical home, and this is SDF, just to give you a comparison. Okay, so it's the highest fluoride product that we have in the United States. It's approved as a class 2 medical device, but and it's used off-label, the same as fluoride varnishes, and it's good. We have data from other countries that suggest that this works really well. As you know, many young kids go to the operating room to treat cavities like you're seeing here if they have a lot of that, and no one wants that. We don't want that either. Really, no one wants that. So the FDA was super interested, and they said, well, what if we need a treatment to prevent this from happening. And they gave breakthrough therapy status to this product, which opened the doors for us to really look at a trial. So we ran a trial. We finished, it ran through the pandemic. You don't want to know what we did to try to do exams of kids on car seats, et cetera, looking through the window so that we could actually we had, and the FDA required a placebo trial. Because this was a drug application, they would not budge on this. We argued that we couldn't paint water on these holes, that these holes tend to advance rapidly. So the way that we got around it is like, fine, we're gonna examine these kids very, very, very frequently, which really creates a lot of cost so that if we see anything going wrong, we will stop it right away, right? There were very, very frequent visits. We also limited it to 8 months. We said we can see the effect of this. We don't have to wait years. CARES trials tend to be years. We don't want to have a placebo for years. And so the trial just finished. So it provides the data to the FDA for a drug claim. You know what the FDA will do with the data. I can't tell you, but it was a very large team that was part of that. We needed a very large cohort of kids. And these were kids with severe early childhood caries. So these are the kids that have disease everywhere at a very young age. The other thing is that the FDA was only interested in the 1 to 5 because those are the kids that normally go to the operating room. So the ones that have severe disease. So these were the very high risk, very, very young. And this is the final data that we just have fresh off the press about arrest rates between SDF and the placebo. They are clinically and statistically significant, but notice the arrest rate. It's not 100%. Right? That this means that there's some of these lesions that this is not working. This medicine just doesn't work. We have some data. We know that the lesions in anterior teeth, so if you have something in the front of the teeth that you can paint, which actually for medical providers is the easiest one, those tend to work pretty well. The ones in the back, kind of hidden in between teeth, where you're trying to do magic, this doesn't work very well. The other thing that we know, lesions that are very big, because they're very open, this works well. The ones that are kind of closed, like a little incubator, that tends not to work very well.
The application of this, the reliability in doing it, how much is that related to outcome?
These are the type of lesions, the type of things that this, it's super easy to apply. You're just painting the solution on the cavity. The problem with the application is that this one's fairly easy, right? You wipe it with a gauze, you paint it on. You don't need to do anything else, super easy. These ones are full of food, and this tend to be the families that don't brush, et cetera. So there's a Cheeto in there, there's everything. So you can't just paint that on top of that. You have to clean that out. You don't have to remove dental tissue, but you have to clean it up so you can paint this on the tooth.
You know, you had said earlier on that the current practice, the teeth have to be dry. You have to use a product that is effective.
That's for fluoride varnishes, yeah.
Okay, with this, how much are you saying, you know, the people in this trial, did they have particular training?
Yes. So this trial was by trained. This was not a practice thing. This were very skilled clinicians
Okay.
that we're applying this at the best possible way.
And would this,
And
the
even-
idea, would this be in the medical setting? or-
Yes, some of this were done in medical settings, so we work with a lot of the U of M clinics, the one in IPSI in particular. We did it in dental settings, but a lot was shut down during the pandemic. We did it in schools and Head Starts and early Head Starts and.
But everyone had training.
Yes, it was our team
Your
going
team.
to all of those locations throughout Michigan.
So once the
et
trial
cetera.
is done and you say it works, do you expect that when it gets out there,
It's out there.
okay, when it's out there, will people apply it in the way that it's supposed to be done?
That's the same as the floor varnish application. Unfortunately, the data suggests when you look at floor varnish applications that people don't apply floor varnish the way it's supposed to be applied. For this product, it's easier. It's much easier and the reaction is immediate. So you don't, for the floor varnishes, you have to tell them, don't eat, don't drink for a while because the varnish has to be stuck to the tooth for a period of time. This is an immediate reaction with the tooth. You put it and it's reacted. So you can go and eat, rinse, do whatever you want. But you need to clean the cavity. So the clinical trials data from other countries though suggest in older kids, no one has done it in kids this young and this sick, if you want to, that the arrest rates are close to 80 and 90% after repeated applications, so that this works really, really, really well. It will stain it black because of the silver, so that the cavity will look black, but many of these cavities are black to begin with.
Thank you.
And it takes the pain away, by the way. It stops the infection and the pain.
The question about, so first of all, it seems surprising that it was required to be a placebo-controlled trial.
Yeah, right.
And if that were not the case, what would have been the other arm and what do you expect to happen in practice?
Yeah, so in practice, this is being used. The dental workforce, this product was developed many, many decades ago and it's been used in other countries for a long time. Because of the cosmetic side effect, it wasn't very popular. It was a lot of seen as an alternative when typical treatment could not be provided. In the US, it got in when it got approved as a medical device around 2014. And since then, every pediatric dentistry program teaches it around the country. Pediatric dentists, if you refer a kid to a pediatric dentist, everyone will know. And like I said, now medical providers also, there's a code that you can use with the idea. I can't imagine that a lot of medical providers are going to be jumping to do this because they're not doing floor varnish. So I have to assume that it's kind of the same thing. Who's going to do it? There's many other barriers to doing this. But it's very easy to do in the front teeth.
But my question is more kind of what would be the alternate pathway for treatment? So
Yeah.
would you have recommended more frequent follow-up with
Yes.
kind of a diversion to getting a cavity filled? And is that what you expect to see happen in practice? Like, are the recommendations for how it's used in practice, I'm assuming are different from what was tested and
Right, so this was tested as an alternative for if you can't go and get a filling, could this stop the disease? And the data from the literature suggested that you have to reapply, so this was reapplied every 6 months. With the idea that every 6 months they would see either a dental provider, because these kids have a lot of disease, so hopefully they would be under dental care, and there would be a reapplication of this strategy.
or a reapplication or a referral to getting a cavity filled if it
Right,
were progressive.
Right, and what happens in practice, in reality, what has happened in the US, because when Medicaid started paying for this in the dental side, I think they assumed we're gonna get less cost of kids going to the operating room and getting fillings. What happened in reality was that happened initially, and then people figure out this is still a hole in the tooth. The parents don't like the color. Food still gets trapped. If the hole is very big, the tooth might crack still and break, and then you have a real root tip, et cetera. So it's a great alternative, but it's not the solution for every problem. And so what ended up being is that this is used many times when you're buying time, but eventually the kid will go into some form of dental care unless the tooth is ready to exfoliate. And then you might be able to hold it without any other treatment. There's no anesthesia, there's no shot. So it's very child friendly to be able to do this. And you could do it in any setting, like I said. Yeah. So that's where we are. The only thing I will tell you is that the difficult part of this, I think in the medical setting, is gonna be that this cavities need to be cleaned unless it's a front tooth. And that you have no way of knowing whether this worked or not, because you will see it turn black. And the black doesn't mean anything. The cavity actually turns hard, and that means that the infection is under control. But unless you have an instrument that you can touch the surface of that cavity, you won't know whether this is working or not. This is an example of the black one that is obviously not working. This hole is getting bigger, right? I don't need to give you any particular numbers to tell you that did not work there. That is getting bigger and bigger and bigger. So thank you. I know we might be, I'm happy to stay and answer your questions.
What proportion of kids see a general dentist, not a pediatric dentist? Because like you said, there aren't
It
that many
depends on the
pediatric
age that
dentists.
you're asking.
Let's say less than 10,
I would say,
because there's not that many pediatric dentists.
right. So if they're young, if they're very young, and they have a lot of need, these kids are probably seeing a pediatric dentist. This is beyond the scope of a general dentist to treat the kids in this trial. They were very, very high risk.
No, I meant just like in general,
Well,
not,
in general, the majority will see a general dentist.
and do they, like you said, all the pediatric dental programs are doing this, are the general dentists?
Yeah,
Okay.
well, I can't say everyone, we teach them, this is, actually, we have it in our adult clinics as well, because for a lot of patients, let's say that you can't afford a filling or something else, but you don't want that tooth to get a root canal or get pulled.
Yeah.
We can stop the disease and the pain and say, okay, whenever you're ready for the next stage, we can do that. Of course, it doesn't work in all cases, but it works in a high percentage of cases, so, yeah, you're welcome.
So, you know, I know that there's a lot of kind of conversations right now about fluoridation of water.
Yes.
Controversy about that.
And toothpaste, actually, Procter and Gamble and Colgate were sued as well recently.
So I'm wondering about the fact that, like, you know, it's interesting because there are many countries that have very, you know, I think sophisticated public health approaches like the Netherlands and Germany that don't fluoridate their water. Is it because that they do a better job of doing fluoride varnish, or what is the rationale for not fluoridating it there?
Yeah, no, but they have also very different healthcare systems. Some of those countries have either free access to dental care for their children and very good access to that care from the beginning with very good provider-dependent preventive programs. Many of them have very strong school-based programs where kids will see and get a lot of this preventive interventions like varnishes or dietary indications, et cetera, in those other settings. So they're getting their prevention from other sources that is not necessarily water. In other countries, you might fluoridate salt or milk, and that is either because the water supplies are not adequate to be able to distribute something in that way, or to give choice, right? Some of the only problem, in my opinion, with water fluoridation really is that you have no choice, whether you want it or not, if you live in a community where it's adjusted to that level, right? But other than that, yes, so that's why in some of those Scandinavian countries in particular have been fantastic at controlling dental disease, but they are doing it based on, in some of those countries it's advocated that parents brush their kids' teeth until age 12. Now you tell me which parent here brushes their teeth regardless until age 12. So the preventive approaches and how they approach prevention of oral diseases is very, very different, and how they reimburse and cover for dental care. Very, very different than in the US. So you could make an argument that perhaps we, certainly you and I perhaps don't benefit too much of water fluoridation if we're brushing our teeth with fluoride toothpaste, et cetera. But there's clear data that there's some in our community that if you took water fluoridation away, there would be an impact. And you see that with some of the data from Canada, where you had some cities that defluoridated, and the risk of disease in kids going to the operating room under general anesthesia increased, and they had to bring fluoridation back for that purpose. So the IQ issue is a completely different IQ. It's a completely different problem. And a lot of those are association studies with very poor measurements of fluoride. There's spot urine checks in mothers, and assuming that actually measures chronic exposure to fluoride, which is not true. And in areas where fluoride is very high naturally in the water, but there's other contaminants in the water that could explain perhaps the neurotoxicity as well. And at levels that we don't have, we don't adjust water here in the United States at, so.
Well, if everyone wants to scan the QR code for feedback, and thank you so much.
Yeah.
Really appreciate it.